So let's get started. I'm Dustin Sulak. Excuse me. For those of you that are new to these healer webinars, I'll tell you a little bit about them and then we'll jump into the content after a couple quick announcements. So healer.com is a free patient education resource. I think a lot of you know this, and it helps people use cannabis to find their optimal dose and to get the most benefit with the least negative effect or with no negative side effects, and also provides education around what people can do with cannabis. Now, at healer.com, we also have a healer certified training curriculum, which is a program that includes online modules and recordings of all these webinars that lead people through what I consider a soup to nuts curriculum that's very easy for anyone at any level to understand and to benefit from, whether you're a patient, a caregiver, a dispensary agent, or industry worker, or a clinician. And so these webinars started out as part of that certified training program. After the COVID pandemic came along, we decided to make them free to everyone live so anyone can tune in and have a chance to learn what we cover in the webinars, which is research that's come out recently that I think is interesting and relevant to my clinical practice and therefore the care of patients. And then a long Q&A session where people can kind of ask questions, give cases, and we can all learn together about what's happening in the world of cannabis. So that's what we'll get started with here in just a moment. But before then, I want to make the quick announcement that at Healer, we have launched our new whole plant hemp topical hydrogel. That's at healercbd.com. So this is a lightweight, fast drying hydrogel topical that delivers both CBD and CBDA, along with a broad spectrum, the Healer spectrum of plant compounds that we capture with our nanofiltration extraction process. The gel is really nice. It's water-based. It absorbs quickly into the skin, doesn't leave an oily feeling. And it's 850 milligrams per bottle, 20 milligrams per pump. So that's 10 of CBD, 10 of CBDA. And there's a little copaiba oil, menthol, and limonene in there for increased penetration and anti-inflammatory properties. So we've been tweaking the formula for a while now, and we've had a lot of people say that it's really effective. And so we're happy to announce that we're releasing this product. And if you have any feedback, I would love to hear from you about it. The feedback that we've been getting on our oral healer CBD products has been fabulous. And you can see that on the website as well. There's a 20% off discount for anyone that's listening to this. The discount code is webinar, and that's for all of our hemp products. And then if you find that this webinar is helpful for you, please consider joining the Healer Certified Training Program, which besides the curriculum and the recording of all these webinars with time stamping of the different topics we talk about so you can get to the information you're looking for quickly, there's also a very engaged online community there that's asking and answering questions and comparing their notes and their results. So that's all the announcements for tonight. Thank you so much for being here on your Wednesday night. I hope you're all doing well. I had a really nice day in the clinic today, a long day with great patients. And if there's time afterwards, maybe I'll share some patient stories. But let's jump into the research. I will share my screen. And now some of you may have noticed that the original topics I was going to cover tonight, once I actually dug into the articles, I was unimpressed with a couple of them. And so I decided to trash them and go to some other ones. Some of you may be disappointed that I am not covering the topic of cannabis and migraine headache and medication overuse headache. And the reason I'm not covering that is because this new data, which made some headlines, it was presented as an abstract at a conference. When I read the preprint version of what they've submitted for peer review publication, I was really unimpressed. And I think it's probably going to change form to some extent before it gets published in a peer reviewed journal. And so I'm going to wait for that to happen. But I'm totally happy to talk about and answer questions about cannabis and medication overuse headache. And there was also a recent article about this that I was interviewed in, and we can get a link to that in the chat so you have some more information. So what we're covering tonight is CBD and its effects on candida, specifically candida biofilms, cannabis use by patients with gynecologic cancers. This is a survey study, but I like sharing the results. I think they're relevant. And then cannabis for preventing and treating chemotherapy-induced neuropathy. And then there's two reviews that are very related, review articles that have looked at a huge body of research and kind of summarized everything. And one is about THC's impact on driving, the other about impairment in medical cannabis users. And then after all of this, we have a special guest presentation from Dr. Charles Harris. He's going to tell us about his results that he's gathered from his medical practice using cannabis in the treatment of autism spectrum disorder. So we'll hear a little bit about that as well. Let's dive in. So anti-biofilm activity of cannabidiol, CBD, against Candida albicans. And if you look at the list of authors, you'll see Raphael Mechoulam, who is considered the great-grandfather of this whole field of cannabis research. And if you're not familiar with Dr. Mechoulam, I highly recommend the film called The Scientist. It's available online. It's extremely entertaining. It'll connect you to kind of the background of this whole body of science that we're working with here. And Dr. Mechoulam has been very interested in the use of cannabinoids to disrupt two things, biofilm formation and quorum sensing. And these are both mechanisms of how microorganisms can resist our body's immune system defenses against infections and also resist antibiotics and other treatments. And so if we can disrupt these two aspects of their physiology, of their biology, then we might be better able to work against these chronic infections and heal from them. So Candida albicans is a commensal microorganism. That means in many situations, it just lives with us and it's not hurting us. It might even be helping us in certain states, but it's kind of just something that we find in people. But it can become pathogenic when it has an opportunity to grow excessively and to infect our tissues. Biofilm formation is one of the most important virulence properties of Candida. It's a biofilm is a highly structured multi-layer network of various cell types. And I mean, some types of biofilms will actually involve multiple organisms. In the case of Candida, it involves multiple forms of Candida. Candida can appear in a yeast form, a pseudohyphal form, and a hyphal form. And these are these different versions of Candida actually have really different capabilities and properties. And these biofilms include glycoproteins, carbohydrates, lipids, nucleic acids, and exopolysaccharides. And these make this gel. And inside this gel, the immune system has a hard time penetrating. Antibiotics have a hard time reaching that. It's biofilm formation is highly adaptive on the part of these organisms to keep themselves safe. And so they secrete this and they build their little microenvironment where they can survive. The most common type of biofilm that people know about is dental plaque. So that's an example of a biofilm. So yeast is a big problem for a lot of people. Probably many more people have an overgrowth of yeast in their body than they know about. And I think it's highly underdiagnosed and underrecognized and undertreated. So let's talk about CBD and Candida. Oh, here's a picture of a biofilm. So you can see the yeast form are these little like circles and ovals. And then some of them have these little projections coming out of them that are the pseudohyphae. And then these long strands here are the hyphae. And so that plus a whole bunch of sticky, gooey stuff that's secreted forms the biofilm. So just a little background information on cannabis and Candida in general. There really isn't much out there about the effect of cannabis and Candida. There's much more research about the compounds in cannabis and their antibiotic properties than there is about their anti-yeast or antifungal properties. But this is one study from a few years ago looking at a moderate dose of THC in mice. And what they found was that mice who had been previously infected with Candida and then were exposed to Candida a second time, basically injected with it to see if they would get a repeat infection or to see if they had built some immunity to it and did not get the repeat infection. Essentially, dosing them with THC compared to a control of a vehicle actually suppressed their immune system response and made it so they were more likely to get that second infection with the candida. And so again, just to clarify that, cannabis is an anti-inflammatory compound. It can suppress certain aspects of the immune system, not the whole immune system, but just certain aspects of it. And that's typically beneficial in people that have too much inflammation because it calms that down. Well, there are certain situations where cannabis might suppress the immune system in a way that's not helpful. Now, how does this mouse data translate to people? Not very well. There's also one abstract that I saw at a conference, and I found it when I was researching for this webinar tonight. But it was looking at I don't think I included it. Yeah, it was looking at vaginal candida infections in mice, and they also found that very high doses of THC made mice more susceptible to the vaginal candida infections, and that's about all we know. So, does cannabis help or hurt yeast? Like, what's in the scientific literature? We have very little information that's translatable to humans. But anyways, here are the new results from Dr. Mashulum's group. And so, first of all, this is the effect. We're looking at a few different aspects of the candida life cycle. The first thing that's being looked at is the formation of biofilm. And so I'll explain this chart on the left here. There are different doses of CBD that they tried. Now, these are not in animals. These are in vitro, like in a cell culture. And so they tried a vehicle, this is the control, and then a low potency CBD all the way up to a high potency CBD. And you can see for each of, and what's high potency? 100 micrograms per milliliter. This is still very weak stuff. So that would be like 0.1 milligrams per milliliter, which is essentially 1/500th of the potency of the healer CBD oil, for example. So these are all low potency CBD solutions that were applied to these biofilms, and each potency has a time course. So you can see exposing the biofilm to this lowest potency for 24 hours didn't have any effect. Exposing it for 48 hours didn't have a statistically significant effect, but a trend towards reducing biofilm formation. But then you can see at 72 hours, even the lowest potency of the CBD solution was able to statistically significantly reduce biofilm formation. And as the potency of CBD went up, you can see there is barely any biofilm formation going on here. So really interesting stuff. And then over here, we have how much biofilm remained after, this was, let's see, after 24 hours, using another assay. So again, the higher doses seem to work better than the lower doses, but either way, they were inhibitory. Let's take a look at some more data. These are, this is the morphology of the biofilm. So over here in box A, you can see what the biofilm looks like when it was not treated with CBD. Here, it was treated in B with the 25 micrograms per milliliter, so kind of a middle of the road dose. And here you can see at 100 micrograms per milliliter, very little biofilm formation there. And even at this moderate dose, it's really disrupting the structure and preventing the hyphae, these long extensions, from growing. It's keeping it more in the yeast form. Okay, here's a little more data. They looked at, how is the CBD doing this? What effect does it have on the yeast? And one way in which it affected the yeast was by disrupting its energy production in the mitochondria of the yeast. And so they measured the mitochondrial membrane potential, and you can see that the low and moderate doses of CBD decreased the capacity of the yeast to produce energy. And when their energy production is decreased, they can't change forms and extend into these more virulent hyphae forms and are more likely to stay as the budding yeast form. And then over here, we have measuring reactive oxygen species. So these are like free radicals, which are destructive to the yeast cells. And you can see that at the higher dose, 25, this isn't the highest they tested up to 100, but at 25 micrograms per milliliter, higher, kind of a middle of the road concentration, there was this significant accumulation of reactive oxygen species, meaning these yeast were having a hard time getting rid of their free radicals, doing their metabolic activity to produce energy, and that's why they were inhibited from their normal activity of setting up a biofilm. And this is looking at their intracellular ATP level. ATP is a basic energy currency in biology. And again, you can see that their ATP was really decreased with the exposure to CBD. So what are the results? CBD increased the membrane permeability. It downregulated several genes related to host invasion. And so these yeast have genes that will turn on to help invade the host, and CBD prevented them from turning on these genes. And then it also upregulated heat shock proteins and cell wall genes, which are kind of a signal that they're putting these yeast on the defense. Basically, it's attacking the yeast, and they're switching on their defense mechanisms to try to deal with that. So let's talk about this. CBD reduced biofilm thickness and the exopolysaccharide production. It impaired biofilm architecture and the integrity of the biofilm, meaning that our immune cells and potentially antifungal drugs could get in there better. CBD caused a striking elevation of clustered yeast and the appearance of pseudo hyphae forms, and decreased the true hyphae mass, and this switch from yeast to hyphae is considered important in the virulence of candida. So preventing it could improve antifungal therapy. These were discussion points from the paper, and I'll go through a couple more and then give my take on this. CBD exerts its own antibiofilm activity toward candida through a multi-target mode of action, which differs from commonly used antifungal drugs. So essentially, we know that based on this evidence that CBD can attack the yeast in several directions instead of just one mechanism of action. And that's usually preferred because then the microorganisms are less likely to build resistance and tolerance and so forth. And thus CBD should be explored for further development as an alternative treatment to combat fungal infections. So I think a lot of you are probably wondering, if we go back, let's just go way back here to these doses, how do these doses compare to levels of CBD that might be able to be found in the body? And so first of all, I compared this to our healer drops that people take by mouth and to other CBD products that are out there, much less concentrated. And same with our new topical hydrogel, much less concentrated. So in a petri dish, at a much, much lower concentration, you can still disrupt candida's activity with CBD. The question is, and so I think that people that are wondering, well, could CBD help if applied topically to a yeast infection? Could that potentially help? My guess is that yes, it could potentially help based on this data, which is not even animal data. This is just test tube data. So we have a lot of work to do before we know how well this works in people. But yes, it could help. These are concentrations that the yeast cells would be exposed to that are certainly greater than what's in this study. Now, the other question is, well, what if I take CBD orally? Am I going to achieve blood or tissue concentrations that are anywhere in this range? And the answer is really no. Looking at CBD concentrations in the blood of people, even after smoking it or inhaling it, people aren't going to have much more than 100 nanograms per milliliter in their blood. And that's a lot lower than what we're seeing in this study, several orders of magnitude lower. However, there might be CBD concentrated more in other tissues or in the lymphatics. We don't have much information on that. And so it is possible that in certain tissues or even inside the GI tract, because we know that a lot of CBD does not get absorbed. It actually gets excreted. And so CBD that's passing all the way through the GI tract could have a beneficial effect on yeast that's in the GI tract. And we have a lot more to learn about this, but I think my point is CBD helps people with a lot of different things, and we already know that it's working via multiple mechanisms of action. And really what we've been thinking about more than anything is what targets in human physiology does CBD have to produce its health benefits? And we're familiar with a handful of those, but I think that this study opens our mind to what indirect mechanisms of action could CBD be acting via to help improve our health. And so many people that have yeast overgrowth, maybe CBD is helping with that. Maybe that's one of its beneficial effects, and we'll need more research to figure that out. But it's kind of exciting and something to think about. And if you're battling chronic disease or learning more about your own health, and you are curious, do you have a problem with yeast? Well, there's a few different ways of looking at that. This last weekend, I actually took a whole course in a test called the organic acid test. It's a urine test that looks at various acids that are excreted in the urine, and there's a marker in there that can give a pretty good idea of your total yeast burden in your body, your candida activity in your body. And so that would be a test to consider asking your doctor about. Okay, moving away from CBD and moving away from yeast, let's talk about people here. This is a survey of 31 patients with gynecologic cancer who used medical cannabis that was prescribed by a gynecologic oncologist in Connecticut. And so this was taken from that person's practice. This was published a few months ago. I think it might have been November or December of 2020, but I never reported on it here, and I wanted to tonight. So these were a little on the older side, folks. The median age was 64, but it ranged from young, 24 years old, up to 75. 45% of these patients had stage 3 cancer, and 29% had stage 4 cancer. So a good 3/4 were in the advanced stages of cancer, and 3/4 of them were actively in treatment at the time of the survey. So here's the results. This is going to be quick, and I'm sure you're used to seeing good results when we ask people, well, how much is cannabis helping you, and what's it helping with? It kind of, regardless of the patient cohort, we tend to see things that look like this. Well, how many people said it helped with depression? 6 did. How many people said abdominal pain? 8. Remember, this is out of 31 total. And so obviously there's some overlap here, but a lot of different symptoms with a lot of responders saying that cannabis helped with those symptoms. And then asking them, well, looking at this top bar, is it better? Is the cannabis treatment better than other medications used to treat these same symptoms? And so 80% said that it was better than other medications they had tried to treat the same symptoms. Just a small, about 10 or 11% said it worked worse than other treatments they had tried. And then there were a few unanswered there. So the vast majority found cannabis was more effective than their conventional treatments for this variety of symptoms: joint pain, bone pain, abdominal pain, all the way through anxiety, neuropathy, insomnia. Cannabis worked better. And then what about the side effect profile? Was it better than conventional treatments? And you can see here about 83 or 85% almost said that it had a better side effect profile than their conventional treatment, and very few said that it had worse. This is not a big surprise to you all, but I like to show you the data. How are people using cannabis? Well, first of all, this was a pragmatically kind of prescribed cannabis. Like how we like to do it, individualized treatment. It's not a single treatment matched with a diagnosis. This is how we treat individuals. And so a lot of people were using multiple forms. You can see if you add these up, it goes way above 31. So I'd say most people were using more than one delivery method, but the tincture or oil sublingual delivery was the most common. And you can group in oral or edible. And so that's definitely the most common, but there were still 10 out of 31 smoking or vaporizing, maybe some overlap there. And then some people using the topical. So that's I think that's representative of what probably a lot of us are seeing and hearing about with our clients, patients, friends, and so forth. High success rates. I've said this before, and many of you have probably read this in the curriculum as well, but I think that there are very few patients that have cancer that would not benefit from cannabis. Usually there's some way for people with cancer to weave cannabis into their life in a way that improves their quality of life and helps them, if they're in active treatment, helps them stay in active treatment, tolerate the full dose of treatment, tolerate the complete course of treatment. It's just so beneficial, and this is just more evidence to support that. Now, even more evidence. This is a study on the effect of cannabis on oxaliplatin-induced peripheral neuropathy among oncology patients. And it's a retrospective analysis, meaning they looked back at charts and gathered all the data and found out what's happening with the people who use cannabis versus those who don't, who take this particular toxic chemotherapy drug, but this is a drug that's in the group of many other drugs that are used across various types of cancer. And these platinum-based drugs are notorious for injuring our nerves. While they're killing the cancer, they have a toxic effect on other cells of the body, and the nerves are usually very vulnerable. And so even in many of the animal studies that have looked at models of neuropathy, and including the ones that have studied cannabinoids and other treatments for neuropathy, they typically use this class of medications to give the rodents neuropathy and then test, can we relieve the neuropathic pain with whatever treatment? Now, there was one rodent study that tested CBD, but not for treating the pain of the neuropathy, but actually for preventing the neuropathy. And it was shown to be effective in doing that. And so the question has been out there for a long time. Well, we know that we can treat neuropathy in people with cannabis. We know that cannabis is neuroprotective. Could it prevent the development of neuropathy? And my position on this is most likely it could. And my patients that use cannabis before starting heavy duty chemotherapy regimens often report that they feel much better than the people that are around them in the waiting room or the infusion center, and other people that they talk to. They feel like they're kind of sailing through the treatment without many side effects versus people who aren't using cannabis. But anyways, this is some data that kind of supports this. So this acute oxaliplatin-induced neuropathy can occur in up to 90% of patients that receive this drug. And for those that develop neuropathy while they're being treated, if they continue their treatment, it can be a severe chronic neuropathy in almost a third of them. So this means if we cure your cancer with this drug, there's a good chance you're going to be left with debilitating chronic nerve pain, which is very, very challenging for people. And but there's still hope. People can get better from that also. There's really no conventional treatment for either neuroprotection, meaning preventing this from happening, or neuroregeneration, meaning helping the nerves heal so that the neuropathy goes away. There's been many trials, lots of agents in animals have been proven to be effective, and when they try to translate that to people, it does not translate. There's been a huge amount of resources invested in the research of how to protect or regenerate these nerves, and nothing's panned out in humans yet. So this study looked at the records of 768 patients that were treated with this chemotherapy regimen, or a variety of different regimens that included these two drugs. They excluded patients that already had neuropathy. And the patients were basically divided into three groups: those who started cannabis before they started the chemotherapy, those who started cannabis after they started the chemotherapy, and those with no exposure to cannabis. These are the demographics of the patients. And I'm showing this because it's important to note that these three groups were not perfectly matched, meaning there's a little difference in their average age. There was a little difference in their gender. You can see the cannabis first group had more females than males. And then the type of cancer that they had was a bit different. You can, in the parentheses, there's the percentages. So, 58% had colon cancer in the control group, but only 40% had colon cancer in the cannabis first group. As far as metastatic disease, 63% were metastatic in the control group, but 85% were metastatic in the cannabis first group. Some differences there. So we're not exactly comparing apples to apples, but that's okay. This is still important data. Let's take a look at the neuropathy grades. So out of all of these, 700 patients, and you can see how they're divided up here. Oh, there's less than 700, and I think these were the final responders. Actually, I'm not sure about that. I'm not sure where all the 700 went. We'll have to get back to you on that one. But let's take a look at the neuropathy grades. So in the control group, 31% or almost 32% had no neuropathy based on their chart review. In the cannabis first group, 75% had no neuropathy based on that chart review. And in the chemotherapy first followed by cannabis group, it was 46%. So you can see a much more than double the percentage of patients that started cannabis first finish their treatment without neuropathy. I'd say that's pretty profound, and that warrants a lot more attention in human studies. And then you can see, just going down the list, what percentage of these people, let's go to grade 3 neuropathy. So the most severe neuropathy, 5% in the control group, less than 1% in the cannabis first group had the most severe rating of neuropathy. And you can see for grade 2 neuropathy also quite a big difference there. Now, this type of data tells us about association. It doesn't necessarily tell us about causation. So for example, maybe the people who decided to start cannabis before their chemotherapy had decided to do other things before they started their chemotherapy, like take other neuroprotectants or change their diet. Or maybe these were just a certain certain qualities in this cannabis first group that were different, that weren't recorded in the study. There's so many unknowns here. So we can't pin direct cause and effect that the cannabis first group was better because they started cannabis first. But I'd say based on the known mechanisms of action and the proven animal data that shows that this can be done, I would say that this likely was related to the cannabis, at least in part. All right. So there's so how do we summarize that? I guess I said it before, and I think if any of you are interested in learning more about using cannabis in patients that are fighting cancer, whether it's to help with their symptoms or even potentially to help have direct anti-cancer effects, we have a lot of information about that in the curriculum. Let's move on to impairment and driving. So this is a review article published in January looking at the magnitude and duration of acute THC-induced driving and cognitive impairment. It reviewed 155 different trials with 3,500 participants that were published in 80 original research studies. And I'm just not going through their methods, which are a little bit beyond me anyways, how they review all these studies that are, many of them are using different measures of impairment and driving, different conditions, different cohorts of subjects and participants. But the experts in doing these systematic reviews and meta-analyses, I'll leave that to their expertise, and I'll tell you about their conclusions. So THC was shown to impair aspects of driving performance. No big surprise there. The magnitude and duration of the impairment depended on the dose, the route of administration, and importantly, the frequency with which individuals use the cannabis. So I think the first two are obvious. If you take more, you might be more impaired. If you smoke it, you might be more impaired than if you take it by mouth, unless you take a lot by mouth, and so forth. And especially the duration is longer if you take it by mouth compared to if you smoke it. But this final point is something that a lot of us know, but I think is really important to see in the literature, that the frequency of use makes a big difference on the level of impairment. So the authors concluded that there's no universal answer to the question of how long to wait before driving following cannabis use. And that's what everybody wants, right? A simple answer. If you use cannabis, like we have with alcohol, if you take one drink, wait 1 hour. Well, that's a decent rule of thumb. I'm sure there's exceptions, people that don't quite fit into that rule. But for cannabis, there's no simple answer like that. A consideration of multiple factors is required to determine appropriate delays between THC use and the performance of safety sensitive tasks. There was a non-significant trend based on all of this data put together showing that THC tends to make people drive more slowly. Now, we've covered other driving studies in these webinars, and this keeps popping up and again and again. And so why does THC make people slow down? Well, it's what they suggest is that drivers may attempt to expand their safety margins, likely due to reduced driving confidence. And I think that's absolutely the case. That's what I hear from my patients. That's what shows up in many other studies. Essentially, people that are impaired by cannabis tend to know they're impaired. And because they have this knowledge that they're impaired, they're going to drive more slowly and cautiously. And that's different from other impairing substances like alcohol, for example, where there's less awareness of the impairment, and people that might not be fine to drive might still say, give me the keys, I'm fine to drive. And I think we've all been in those situations where we've said, no, you're not fine to drive. I'll take those keys back. So that's a lot less likely to happen with cannabis. Now, this is really interesting. A few months ago, we covered one study that looked at the combination of CBD and THC in drivers versus THC alone. And actually, in that study, it showed that CBD seemed to inhibit their lower confidence, right? So when they were asked, how confident are you that you could drive right now? In the absence of CBD, people were less confident and therefore more careful. But in the presence of CBD taken with their THC, they actually felt less impaired, even though they weren't really less impaired. So interesting finding there that CBD could potentially reduce this kind of safety net that people have when using THC in terms of their awareness of their own impairment. The researchers also found that regular cannabis use, either weekly or more often, was associated with less cognitive impairment following acute THC administration. So the more often you use THC, the less likely you are to get impaired through using it. And that is not, that's not just measuring, oh, well, this person's a regular cannabis user. They know how much to use. So they're using the dose that's right for them. Because in these studies, there was a set dose. Most of them had a set dose that was administered to people. And what they found was that the more regular users were less impaired. In non-regular users, the analyses suggest that impairment would take about 5 hours to subside after inhaling 10 milligrams of THC. And so how do we translate 10 milligrams of THC? Well, if you're using kind of low quality cannabis, say it's 10% THC by weight, and I don't mean low quality, maybe it's just your weak backyard cannabis that's not the super potent crystally stuff you see in dispensaries, but it's might still be good quality. So if you're using this lower potency cannabis, say it's 10%, well then that would be 100 milligrams of cannabis flower, which is a tenth of a gram. And so I think a lot of you can imagine a tenth of a gram, just a tiny little bit of cannabis smoke. In non-regular users, they could still take up to 5 hours before their impairment subsides. And the results suggest that impairment would take about 10 hours to subside after taking oral THC at a dose of 20 milligrams. And I don't think that's a surprise to any of you. People that aren't used to taking 20 milligrams by mouth are in for a surprise if they do so. It might not be pleasant, but it might be. So then they specifically mentioned clinical populations. Now there weren't a lot of studies. The majority of these studies were in non-clinical populations, but there were some that looked at people who were using cannabis for therapeutic purposes. And what they found was that there were subtle effects of the cannabis on driving, but in almost all of the instances, these were not statistically significant. So maybe there was a trend toward impairment in these medical users, but not even close to a robust impairment in the medical users. The authors commented this could partly reflect the low doses of THC that were administered in some of these medical studies, but also these doses that they were using were sufficient to elicit some therapeutic effects. And this brings us to this concept of therapeutic window that I've been talking about for so long, which is that in medical users, there's usually a dose that's therapeutic, meaning it relieves your symptoms, it makes you feel better. And then there's usually another dose of THC that causes impairment. And a lot of people that come into my practice, they think they're going to need to be up here at the impairing dose of THC to achieve a medical benefit. And of course, they don't have to. The goal is to get them in that window because they want to feel good. They want to be functional. They don't want to be impaired. There's a variety of strategies for how to widen that therapeutic window, and those are included in our curriculum. And if we have time later, we can talk about them. The window tends to widen itself over time. And then the other caveat is that once people are in that window for a long time and they really don't go above it into the realm of impairment, then I start to encourage them to do that every once in a while in a very safe environment where there's no requirements and no safety sensitive performance skills that they'll be undertaking, because what's considered impairing when it comes to functioning in a safety sensitive task is actually it's the opposite of impairing. It's what can we say? It opens doors. It facilitates other types of internal activity, like reflecting on oneself, gaining a perspective on your illness and your disease, finding creative solutions to your problems, having a deeper enjoyment and connection to art, music, sex, food. All these other things can be enhanced by the psychoactive effects of cannabis, which are certainly desirable in certain situations, not while driving, though. Okay, that was a good tangent on therapeutic window. And then there's this possibility that THC ameliorated clinical symptoms that were previously impairing. And this was, an obvious example of that would be multiple sclerosis. Well, if someone's having spasticity and difficulty controlling their limbs, then when cannabis treats that spasticity, they're probably going to do a better job driving. And there's many symptoms that kind of fall into that category. And so that was another reason why these authors suggested that they didn't see much impairment in the medical users. So a handful of reasons, but I think the bottom line is that medical users are much less likely to be impaired by cannabis. Let's move on to the next big review article on cannabis and impairment. And this article was all about medical cannabis, published by my friend Caroline McCallum out of Vancouver. She wasn't available to join us for the webinar tonight, but we'll probably have her on sometime. She's a great cannabis clinician. And her and her group reviewed 37 relevant studies. And then out of those 37, they just took 7 of them that met their inclusion and exclusion criteria. And they synthesized these 7 studies together into this review. 6 were randomized controlled trials. 1 was an observational clinical trial. And so I'm again just cutting to the chase of their conclusions, not giving you their methods. What did they find? Impairment is THC dose dependent. Big surprise. The more THC you take, the more likely you're to be impaired. There are exceptions to that. And of course, the exception is when someone gradually builds up to a high dose of THC. If they do so, they're unlikely to be impaired by that dose. And I've seen people taking 1,000 milligrams of THC per day with 0 impairment. So high doses aren't universally impairing. It really depends how accustomed people can be to those high doses. Acute impairment was statistically significant in the following domains. So these are the types of tasks that became impaired. And you can see these are both cognitive and motor tasks. So immediate and delayed verbal recall. So if I gave you 3 words, can you repeat them back to me now? Can you repeat them back to me in 5 minutes? Processing speed, so how fast can they add and subtract and stuff like that. Task switching, so changing between different tasks, how well they do with that. Visual attention, fine motor coordination, so that's a motor skill, and working memory, meaning how many kind of different thoughts can they hold, or figures or numbers can they hold in their head at once. That's working memory, and then be able to use them. So a lot of different domains. I think that's the big point here, is that cannabis can have a negative impact on many of those domains. And this was kind of summarized in this nice graphic that they provided, showing that, and again, this was a focus on just medical users. What are some of the modifiable and non-modifiable factors in how impaired someone becomes when they're using cannabis? Well, they were suggesting that comorbidities, meaning certain medical conditions, could impact this, how some people could become more or less impaired with cannabis. And again, I think that has a lot to do with their underlying function and how much cannabis is helping them. Their genetics and metabolism. So we have these enzymes in our liver, for example, that help break down the cannabinoids that we take. And some people might metabolize these cannabinoids more rapidly or more slowly. And then their personal, family, mental health history. But I kind of group these 2 things together. And there's probably many other factors that we haven't thought about. What does it come down to? Some people are really sensitive to THC. Some people are kind of in the middle, and some people are barely sensitive to THC at all, not having anything to do with prior use history. I see someone in the office that has never tried THC before. I don't care if they're young or old or big or small. I have no clue if that's a 2 milligram person or a 20 milligram person. And there's probably a number of factors that influence that response, and we just don't know. So what do? We start at 2 and work up to 20 if we need to, But there are a number of modifiable risk factors. And so route of administration, we already talked about that. Smoking is going to have a more rapid onset, and it's typically more psychoactive than appropriately dosed oral consumption. Of course, taking too much by mouth can be extremely psychoactive and impairing, but let's just talk about kind of appropriate doses here. So if someone's treating a medical condition with inhalation, often that therapeutic window feels very narrow because the increments are 1 inhalation. So maybe they take 1 puff and they're not therapeutic. they take another puff and maybe they are therapeutic, and they take a third one and now they're above the line, they're in impairment zone. So that's, one toke over the line is the old refrain about that. But some people might be below the line. They take one toke and they go all the way over the line, right? So the window can seem very narrow with inhalation, especially in people that are sensitive to cannabis, where if they're taking it by mouth, they can increase their dose in little, like 1 milligram or even half milligram increments, and therefore get right in that window. The window feels a lot bigger when the dosing becomes more precise and incremental. So that's route of administration and dose. And then there's the chemovirus. So these would be the types of cannabis. And this is, there's some types of cannabis, some varieties that are going to be more impairing and some that are less impairing. And we've known about that for a long time. This can be independent of CBD content. So cannabis that has more CBD in it, what we call type 2 cannabis that has a good amount of both CBD and THC, or type 3 that has more CBD in it than THC, well, these are going to have less THC, so they're going to be less impairing. But even beyond the CBD content, certain THC dominant varieties of cannabis seem to be less impairing than others. And this likely has to do with all the other constituents that are in there. And there's drug interactions. There's certain drugs that could slow down or speed up your metabolism of THC. There's the combined use with alcohol and other sedating substances, which of course a lot of people are using cannabis in combination with other psychoactive substances, often because they want to reduce their use of these other substances. So like people that are taking opioids or benzodiazepines or alcohol, they can start using cannabis. That might make them more impaired, but typically allow them to reduce their dose of these other drugs. And then tolerance, so greater than 4 times per week. People were much more tolerant to the side effects. So in this data, that's kind of where the cutoff was. 4 uses per week. There was a big difference in how impaired people were. Neurocognitive impairment following cannabis inhalation is less than or equal to 4 hours in medical cannabis patients, independent of their dosing regimen, be it daily, intermittent, or infrequent. So that's interesting. People that are really looking to put their finger on, well, what's a time frame that I can use for inhaling cannabis? Based on this data of just medical users, it looks like there's nothing in the literature to suggest otherwise. You can smoke, and then 4 hours later, you're probably good to drive. For most people, I think that's a pretty safe rule. And that's the end of the show. Wow, thank you. We went through that really quickly. No, we didn't. That was 45 minutes. It felt quick to me, but I hope these were points that are useful for you. I'm going to stop the share. And now if Dr. Harris is available, I would love for him to share with us his data on his patients with autism spectrum disorder. And if he's not, then I'm going to jump into questions. What do you think, Simone?
Yeah,
I'm just trying to get unmuted.
There you are. Awesome.
Hi, Dustin. Thank you so much. These webinars you do every month are just awesome. So thank you for all that you do for us. That's amazing.
You're welcome. I'm so flattered by all of you who show up to listen to this. Thank you for being here. It makes my night.
Well, I've been doing this for a little over 3 years, and my very first introduction was a 4-hour lecture that was given by you. And so you're the pebble, and I'm the ripple in the pond. So
all right, great. Thank you.
A lot of effect. I sent you some slides. I have some here. I'm not sure if I can do a screen share. Let me try. Is there a screen share button down here?
Yeah, on mine it's at the bottom. Yeah, looks like you got it.
Okay, I can't, that's good because I can't see anything on mine anymore.
Oh, well, what you're sharing, it's strange. It's just kind of like the top of a window. We don't, for some reason, have the whole window.
Yeah, I don't know. Hold on.
But if they're the same slides that you emailed me a while ago, I don't know, have you updated them? Because I do have them handy if you'd like me to.
Yeah, if you have them handy, that's good. They're here, they're just hiding. There we go.
There we go. Great.
You got that? Okay, great. We'll get underway. So thanks. This is just 21 of my patients. I've probably seen about 100 patients with autism, and you did that review of Dr. Aran's publication from early February. And thank you so much. I've been waiting for a year and a half for him to get that published, because that's the first double-blind, randomized, placebo-controlled study that we have. showing a 50% improvement. 50% of the kids had improvement of at least moderate to very good improvement of their symptoms versus I think it was 20% placebo. And that's huge. I mean, I'm an emergency physician. We had stroke data that was worse than that about 20 years ago, and it changed the whole treatment of stroke. So, a 30% over placebo improvement, that's, the number needed to treat is 1 out of 3. So I just collated my data from last summer, 21 patients that I was able to get kind of a pre and post screening. I used the Autism Parenting Stress Index, a little bit modified, but not much. And just briefly, I kind of combined data on 3 slides here. Of my patients, the symptoms, there's 14 symptoms listed on that. And the one that was most common was tantrums. And of our patients that had tantrums and meltdowns as a primary, kind of a core symptom, 100% of those patients that had tantrums were improved. And the average improvement on those patients was between moderately improved and greatly improved. So my scale is just simply 1, 2, 3, mild improvement, moderate, and markedly improved. So a lot of improvement in the area of tantrums. As far as socializations go, about 90% of those who are having a lot of problems with social interactions, and this is predominantly with family, but also classmates, about 90% improved. The average improvement was a moderately better. Aggressive behavior, this is aggression against others, about 90% were improved, and the average improvement was pretty significant at the 2.5. Sleep is a big problem with so many autistic kids, and as you know, patients all across the qualifying conditions that we can use for medical marijuana, sleep is a big issue, and it's one of the areas where we see the best improvement. About 87% of the kids who had sleep issues improved, and their average improvement was very close to very significantly improved. And then restlessness, bowel problems, which is almost always constipation, self-injuring behavior, and communication difficulties, all had very significant improvements in up to, in the 80% of the patients that had those problems. Now, the data is skewed, of course, because these are only the patients that followed up. And I lose about 50% of my patients to follow up. I would split those into thirds, probably a third because it doesn't work, a third because it's too expensive, and another third because they go see some other doctor. So these are very skewed data, but it's still in line with all the other observational studies that we see. And some of the, the kids that I see just have really miraculous results overall. It's the sort of thing where, as you've experienced so many times, when you see these incredible results, you just want to shout it from the mountaintop.
Absolutely. Okay, and tell us a little bit more about your practice. Like, what was your background and what happened 3 years ago that got you into cannabis medicine?
I'm an emergency physician. I'm medically an extremely conservative physician. I never used marijuana at all, ever. High school and college, especially college years, I was more on the beer spectrum than the cannabis spectrum. So when cannabis, medical marijuana came to Pennsylvania, my wife said that we should take a look into that. She's a critical care nurse, and we had family members out in California and Colorado who said that they knew people that were having great results. So I was extremely skeptical. I was pretty sure that this was just a way for stoners to get more weed, and but I was open to at least take a look. My first experience was with you. We did a 4-hour seminar, and even at the end of that, I mean, the data the information was very compelling, but it really looked like it's too good to be true. I think this is all just snake oil, because you would talk about how good it does in pain control, how we get patients off of opiates, then how good it is for anxiety, for sleep, cancer symptoms, and kind of across the board. And after a while, I was thinking, well, there's no one medicine that does all of that. I mean, what route, what's the mechanism that one medicine could help, with all of those symptoms. So fortunately, of course, your lecture was extremely well referenced. So I just started looking up all of your references, and one after the other, it was, peer-reviewed journals. They were really well done studies, and, really well thought out discussions and conclusions. and enough that my wife and I opened up a small practice. We were literally in a little log cabin out in the country, and we started seeing patients, and within a few months we started seeing some great results, and the results really speak for themselves. And now, we're in the office 2 days a week. I still practice emergency medicine half time, but those 2 days a week we're in the office, it's guaranteed that I'm going to hear several amazings, and at least one, it has changed my life. And that's just, that's not something that you hear in any other branch of medicine that I know of.
I hear that so often. Wow, thank you for sharing. And I think as an ER doc, you're probably out of many fields. Doctors from all different specialties are moving into the cannabis world,
Right.
and I think there's a lot of reasons for that, including just dissatisfaction with the grind of the medical system and a lot of other factors. But as an ER doc, you're so used to a wide variety of pathologies walking through the door. You're like the ultra generalist, and can see anything. And I'm sure that cannabis has been a continuation of that for you.
It really is, and our autistic kids, especially, the parents are literally at their wits' end. Of course, it's such a devastating illness, and we see kids through all levels of impairment. And I call some of them our ping pong kids because they come into the office and they run from one wall to the other, to the other, to the other for 45 minutes. And but they can't find a provider. They call, they get on the list and most of the practitioners don't see kids, and they're just going like, no, we don't want to do this. But I've probably seen 20 or 30,000 kids in my practice in the
Right.
ER with all sorts of medical and traumatic injuries. So I was very comfortable, seeing kids. It was getting data that I was literally panicked trying to find data. At that time, there was one little study out of Chile, 21 patients, an observational study. And
Yep.
it's been getting bigger and bigger, and more basic science research from Spain and Italy and Israel. And it's just, the US, it's been amazing journey.
Wow, thank you. And then in these patients, I'm guessing that you were free to kind of customize their treatment based on their needs, right? Like these patients are probably all using different frequency and dosage of THC and CBD.
They really are. A lot of that is driven by the dispensaries. Our dispensaries in Pennsylvania, there's a pharmacist on duty all the time at the dispensary. So they have been key in guiding those therapies. Again, with the lack of data, it's very difficult to give patients information on dosing, which is, like I said, for the first, half year, I was frantic trying to find the dose. What's the dose? And of course, the answer is it's the dose that works. The kids that I see, the dosing is pretty much across, all over the dartboard. And I'm the one thing I'm thrilled by is that almost none of our patients, well, we maybe a handful of patients with autism are on high dose THC. Almost all of them are on the really balanced, anywhere from 1 to 10 THC to CBD, 1 to 1, 1 to 4. Straight THC probably at bedtime only. The teenage patients are more, especially the aggressive or agitated patients, are more heavily onto the THC. But even with that, we don't have kids that are taking 50 or 75 or 100 milligrams of THC a day. We're just not seeing that. We're seeing really good results at really low doses.
Great. Yeah, that sounds a lot like my practice. Well, thank you so much for sharing, and congrats on your involvement in and becoming a leader in this field, sharing your research. Thank you so much. It's really
Well,
kind of this like reverse inspiration thing. I don't know. I feel even better about the work that I'm doing now, hearing about the work that you're doing. So thanks.
you're very welcome, and thank you for everything you do. It's just you're such an amazing educator. We actually give all of our patients your website information because we encourage them to join to take a look at your website. There's such good information there.
Thank you. Wonderful. All right. Well, let's dig into some of our questions. So for the next 30 to 60 minutes, we're going to be asking live questions. I love it if you turn on your camera and your audio. And well, basically what you can do is just put a little message in the chat, and Simone will queue you up for asking a live question. And then I do my best to get to the questions that were previously submitted, which I'm going to pull up right here. And I wanted to start with one from my someone I know that I've met at conferences, Dale Deutsch. Dale, are you on the webinar? I thought I might have seen you, but the videos jump around so much. Well, if Dale, oh, I see you. You're there, Dale. Well,
There I am.
I
How
don't
are
know.
you?
Oh, all right. I don't know if you
Hello.
want to ask your question live, but so for everyone, Dale is primarily an endocannabinoid system researcher, and so we've met together at ICRS before, and he's made some really significant contributions to our understanding of the endocannabinoid system, and probably knows less about cannabis and cannabis therapeutics. So I'm very happy to help you, Dale. What can I do for you tonight?
Well, I was just wondering, I've seen people say that you take THC and CBD, and during the day and the night, there's different preparations. And I look at it, they say that in daytime, the amount of CBD is tiny, and at night it's a little tinier. And I'm just wondering if that really, if that's really accurate, that little bit of CBD will make people awake during the day as opposed to nighttime.
Yeah, great question. And so the answer is no. I don't think that that's accurate, but I will say that if you had two different formulas that looked almost the exact same on a lab test in terms of cannabinoid levels, and even if they looked very similar, not the same, but similar in terms of their terpene content, there can still be quite a subjective difference between whether people say these are sedating or stimulating. And so I think that we're looking at the tip of the iceberg, and there's something below that. It might have to do with I'm not sure what things that we're not really looking for, but that's so that's been one of my findings. And we developed with our products that we have in Maine and also in Maryland, we developed a healer day and a healer night formula, for example, and these are both THC dominant. The day formula, we left a little bit of THCA in it, so it was a little less decarboxylated, but very similar on paper in terms of the lab results. But our starting material, we basically surveyed a variety of cannabis, chemovars or cultivars, and we chose a few that were known to be stimulating and reported to be stimulating by people who use them, and we put those into the day formula. We chose 4 that were sedating. We put those into the night formula, and about 10% of a big mix in there as well. And these two formulas are drastically different. Both of them have almost no CBD in them, but if you look, there'll be a little CBD. I just don't think that CBD makes the difference. So hopefully this answers your question. I will say that the formulas that have more CBD in them are not necessarily less sedating. And one potential reason for that is because a lot of the varieties that are CBD dominant also have a lot of myrcene content. And that's a terpene that's known to be a sedative. So even though, as I'm sure you're aware of, in studies of purified CBD, it seems to have an alerting effect. These broad spectrum plant composition compounds of CBD might not be alerting, they might be sedating.
So thank you. So the variety is very important.
Sure is. Well, thank you for attending. I'm so flattered that you're here, Dale, and I hope we can meet again in person sometime.
Yeah, not in Israel, I don't think. But
No, probably not. All right. Do we have, well, I guess that was a live question, even though it was previously submitted. I just want to take Dale first. So I'm going to ask another question here. This is from Mindy. She says, I have a client with a yeast infection in his ears. Would the topical application of CBD oil be helpful with or without oral or sublingual ingestion? So great question. And I think we answered that tonight based on this very little bit of kind of petri dish data, which is different. It truly is different than what's happening when there's an infection in living tissue. But based on the only data we have, it looks like typical concentrations of CBD oils would have an anti-yeast activity, or at least could have an anti-yeast activity in, say, somebody's ear. Now, yeast otitis externa, so just to clarify, most of the yeast infections are not behind the eardrum, they're outside of the eardrum. So otitis externa, there's a lot of good treatments for that besides, conventional antifungals that are known to work well. Vinegar is an incredible treatment. You can look up how to mix vinegar with water or how to mix vinegar with isopropyl alcohol. And there's good data on that being effective for otitis externa. So even though I'm a cannabis doctor in my practice, when someone comes in with that condition, I'm usually recommending vinegar as a first line agent. And I don't think that's going to change after tonight's data came out. But would a systemic dose of CBD be harmful for yeast? And I think that's something that there's nothing that I'm aware of in the literature that suggests that would be the case. So I think that it'd be okay to take CBD for whatever other reason one's taking it. I wouldn't expect taking it orally to clear up the ear though, but it probably wouldn't hurt either. Okay. Yeah. So, and I see, when I was doing the slides, I don't get a chance to look at the chat, but now I'm seeing some of them. And the question is, what about apple cider vinegar? Yeah, apple cider vinegar is a good vinegar. You could use white vinegar also. I think it's really just the pH, but apple cider vinegar tends to have some other components in it, and it could be a live apple cider vinegar that might even be more effective. It's a good point from Alexander. All right, Simone, any live questions?
Yeah, we have Sergio.
Hi, Dustin. Hello. I have a question related with the pharmacokinetics of cannabinoids and the translation of the results that we observe in the literature, in the papers, with the basic science. Most of the articles, they do treatments on animals, for example, 10 milligrams, 20 milligrams of THC per kilogram. If we translate that into humans, that would be 800, 1000 milligrams of THC, which is a super high dose. Same for papers in vitro literature. Most of the anti-cancer properties of cannabinoids in cancer cell lines, they go in the micromolar range. All right, so if we do the translation of micromolar into the plasma, would be around 30 milligrams, micrograms per milliliter of cannabinoids in the plasma, in the bloodstream. In other words, the doses that are shown in papers, they are super, super high, right? Both in vitro systems and in vivo systems. So my question is, how can we really translate the studies done in animal models and also in vitro models with the biology of humans? Because on most of the cases, the highest doses that we can get of cannabinoids of THC is around in the nanograms per milliliter, right? Which is not so high.
Right. Yeah, it's a great point. Well taken. So, especially on the in vitro side, they're looking for doses that work in those studies, and that's, it's so different than a complex system. Like there was some data that came out of a researcher here in Maine a few years ago looking at breast cancer cells, and she compared her in vitro versus in vivo in rodents. And what she found was that the concentration of, I think it was THC, but it might have been CBD, the concentration of the cannabinoid that inhibited the cancer cells in vivo was much lower than in vitro. Why was that? Well, maybe there's other aspects of the immune system that are attacking the cancer and working with it's just such a complex system, when you have simple cause and effect in the Petri dish and all the stuff we don't know about in vivo. And for those of you that are listening that aren't familiar with these terms, I apologize, but in vitro means not in a living organism, and in vivo means yes, the experiment was done typically in a rodent. And then as far as translating rodent data to humans, a couple caveats. I think a lot of researchers discuss this concept of allometric scaling, and they usually divide by 6 when they're going from rodents to people or somewhere around there. So like if the rodent's getting 6 milligrams per kilogram, which they're not, they're usually getting more, but just to make it simple, then the equivalent in a human might be 1 milligram per kilogram. And I think there's a lot of other big differences. But so when you read 20 mgs per kilogram in a rodent, that shouldn't sound as big to you as it would in a person. Now, in my clinical practice, the patient I've seen on the most cannabis, 50 milligrams per kilogram. I don't see many that high. That's extremely expensive. Thousands of milligrams per day in an adult. I think he was taking about 5,000 milligrams per day. And he was using it in an attempt to treat squamous cell carcinoma. But incredibly, people can survive that. They can tolerate it. He could drive. It was, and that was a combination of THC and CBD. But yeah, the dosing range is just so incredibly broad. I think the other big caveat that isn't talked about a lot in translating rodent data to human data is that the rodent CB2 receptor is quite different than the human. And so I think it's probably easier to translate CB1 dependent mechanisms than it is CB2. And that's a theory. But thanks, great question. We're digging into the science tonight. Thank you, Dale. Thank you, Sergio. Who's next? Or I'll go to the spreadsheet next, and then we'll take one live after that. So the next one is from Mary. Is there any hope for someone who has neuropathy from chemotherapy, which occurred 4 years ago? Is it too late for me? And my answer to you, Mary, is no, it is not too late. It's never too late. I believe in health. I believe in healing, cannabis related and non-cannabis related. I've seen people recover from distant neuropathy and maybe not make a full recovery, but I've absolutely seen it get better. And not just under the influence of cannabis, but even when the treatment is removed or temporarily discontinued, there's still an improvement in baseline. So I think this whole concept that we presented briefly tonight of neuroregeneration, that it's something that's been explored in the literature, and how can we help these nerves repair themselves and regrow? Because often the body of the nerve isn't dead, it's just that the nerve is injured and malfunctioning. And so, yeah, I think neuroregeneration is possible, and I would certainly consider cannabis as a potential, way to induce that neuroregeneration. And there's many other neuroprotective and neuroregenerative potential therapies. Again, like I said earlier, there's so many things that have worked in the animal studies that haven't panned out in the human trials, but that doesn't mean that they're never going to work for you. It just means it wasn't statistically significant in the clinical trials. And there might be things like alpha lipoic acid or glutathione or just magnesium, so many other things that can protect and promote nerve healing, not to mention the signals coming from your inner pharmacy. And so there's so many endocannabinoid and endocannabinoid-like molecules, and then all these other aspects of our physiology that ultimately stimulate a brain-derived neurotrophic factor and some of these other cell pathways that cause the nerves to grow. And probably the one that we know the most about is exercise, right? So that the same type of activity that will increase muscle mass is also going to stimulate nerve growth. And I think there's thankfully there's a big trend in people with neurodegenerative conditions working to get exercise as part of their treatment plan, because this can promote healing. And so and when I say exercise, I especially mean the type of exercise that would stimulate muscle growth. So strength training seems to be especially important. But yes, please maintain hope. Nerve healing is possible. I'll just give a shout out to one other modality that I'm certainly biased about, but this was kind of my first love in medicine and something I still do every day, and that's osteopathic manipulation. And in particular, the form that I do, which is a cranial osteopathy or biodynamic osteopathy, which can improve the flow and circulation of cerebrospinal fluid and its distribution out into the periphery, which has neurotropic properties. That's a modality that I really like. And if you're looking for a good cranial or biodynamic osteopath in your area, you can check out jamesjealous.com. We talked about him last month. He was one of my mentors that recently passed away, and everyone on his website is highly trained. There's also the Cranial Academy. I think it's cranialacademy.org, but you can find it, and they both allow you to search for a physician. All right, longer answer than was probably needed. Who's next for live, Simone?
We have Shell next, and she's unmuted.
Hi, Shell here. And yes,
Hi,
that's my real name.
Amazing.
No, that's love. That's not amazing.
That's love. Well, I like, you can tell I like individualization and people that are unique, and you seem to at least have gotten an early start with that.
Thanks. Got to try with a name like that. I actually have two questions for you. One being, I was sitting with a nurse anesthetist last night, and she was interested in learning more about, patients coming in that have used cannabis, and her fear is, from a medical, from her standpoint, cannabis or THC stays in the system for 30 plus days. How are anesthetists, nurse anesthetists, and anesthesiologists supposed to, know when to, and if to tell people to stop using cannabis prior to surgeries and anesthesia? And then question number two is, you had mentioned in one of your earlier podcasts or webinars, excuse me, that you were involved in a receptor test for cancers, because I've been watching a lot of your webinars about the fallacies of whether somebody should take if they're on immunotherapy or if they're HER2 positive or negative cancers. So I know that you said that you had started, a test to look at different types of cancers and the endocannabinoid receptors that are on those cancers. So what's up with that?
Great questions. Okay, I'll start with the first one, which is that, so there's a little bit of data that has shown that cannabis users may need a higher dose of propofol or propofol and fentanyl for anesthesia. There's no data that I'm aware of that's looking at any other anesthetic agents. There was what's called a consensus document produced through the Delphi process, which is basically getting a bunch of experts together and asking them to agree or disagree on certain answers based on their clinical experience, since the data is lacking. And that was published recently. And in a moment, I'll pull it up and I'll put the link in the chat. I didn't cover it on the webinar because I didn't think it had a lot new to offer, but that would be the perfect document to give to this nurse so that she could be informed. But, anesthesiologists have to be nimble and ready to adjust their treatment based on how the patient's doing. And so they do their kind of pre-surgery interview, and I think the patient should be forthcoming and tell them they use cannabis. And since the anesthesiologist may not be familiar with this literature, they could suggest, that this may mean I might need a bigger dose of propofol or propofol and fentanyl, but maybe not. And I will say that having done this for 11 years, enough of my patients have come back and told me that the anesthesiologist was surprised, or even the dentist was surprised by the amount of anesthesia that was needed to get good results. So there might be something to that, but there's just not a lot of data yet.
Okay, thank you.
So, but I think it's worth telling the anesthesiologist about it, and then, letting them do their job. So the other question you had years ago, I think this was probably 2014, 15, maybe even longer ago, I'm not sure. We, at my practice here, we realized that it would be valuable for people to know if their biopsied cancer tissue had CB1 or CB2 receptors on it, or at the time we thought it would be valuable. It looks like, some of the data that's come out since then has kind of confirmed our suspicions. And there was a pathologist working here, and rather than just kind of take that tissue and homogenize it and test it for the receptors, which isn't a very good practice because blood vessels have cannabinoid receptors, nerves have cannabinoid receptors. There's no real sense of, is it coming from the cancer or is it coming from these other tissues that are involved? We wanted to be able to look at slices under the microscope and stain them for CB1 and for CB2. And what we found out was that there are no good immunohistochemistry antibodies for CB2. This is a problem that the research world has been dealing with for a long time. Dale, if you want to come back on and comment on this, you probably know more about this than me. Maybe Simone, unmute him just in case he wants to, or maybe he wouldn't like that. Who knows what he's doing? He turned off his camera.
Come on, Dale.
Text if you want to join back in. But, essentially, we were extremely frustrated that we bought the best CB2 antibodies, we tested them, and we really didn't get clear staining and good results. And so at that point, we abandoned the project. Now, what I've learned since then from Dedi Meiri's group out of Israel, based on his in vitro work, is that it looks like CB1 is making a big difference, and CB2 isn't quite as relevant. And so probably if we had stuck with that project and brought it, to market so that people could have a slice of their biopsy sent to a lab and be stained for CB1, that would still be valuable information. I'm not working on that anymore. If anybody wants to pick that up and run with it, please contact me. I'm happy to share with you and support you the work that we invested into that. But I think that would be very useful for a commercial lab to offer CB1 staining of cancer biopsies.
So here's a question though. So the majority of CB1 receptors are in your brain and in your spine, in your, CSF and all the whole, and CB2 receptors are supposedly everywhere else. So how would that translate into a cancer diagnosis if it did not originate in the brain or the spinal canal?
So, that's kind of an old thinking process. It seemed like originally, yes, CB1 was the central nervous system receptor, and CB2 was out in the periphery. But now we know that's really not the case. I mean, you'll see CB1 in the gonads and in the connective tissues and in the blood vessels and really all over the place. CB1's all over the place. It's just not as densely populated in the periphery as it is in the brain, but it still appears in all these different tissue types. It's in the gut. It's everywhere. CB2, we used to think it's really just on immune cells. Now we find it on other cells as well. And we find it in cells that don't normally express CB2. They start to do so when they become injured and inflamed. And so they're really all over the body, but you're right, there's really high concentrations of CB1 in the nervous system, lower in the periphery, but truly all over. And the idea behind this research, which I guess I didn't explain, is that cancers that have CB1 receptors are more likely to be susceptible to the anti-cancer effects of THC. And if they lack the CB1 receptor, they're less likely to be susceptible. So say someone was electing to do or considering doing a high dose THC approach to help fight their cancer, I think it would be very useful information to know whether their cancer has CB1 receptors or not.
Like, I don't feel comfortable, and I've been watching a lot of your webinars, especially dealing with cancer and those that are, according to you, older fallacies about, immunotherapy. And that's why I became really interested in what the CB1 and CB2 receptors on the actual cancer cell. Because I myself, I'm a little concerned about saying, okay, well, if I have a patient that comes to me and says, I have a HER2 positive or whatever type of cancer, I don't know if I feel that comfortable saying you can go high if they want, curative and not just symptomatic.
So, I'm glad you're bringing this up. It's been a while since we covered it. It is covered in the Healer curriculum, but the idea is that if you're using cannabis to try to fight the cancer or cure the cancer, and when most people do that, they use large doses. That's not always necessary. There's certainly case reports with lower doses helping, but the vast majority of everyone that's ever told their story about cannabis killing my cancer has used these heroic doses. If somebody's going to do that, they need surveillance. They need to know whether or not the cancer is responding to this treatment. And if it's not responding, stop the treatment, because it's possible that the high dose of cannabis is suppressing your immune system's ability to fight the cancer, right? So if the cancer is vulnerable to cannabis, then the cannabis is probably a good idea. But if it's not vulnerable to cannabis, the cannabis could be making things worse, especially at high doses and in the absence of other definitive treatment for the cancer. And so, yeah, it's a complex picture. I think we do a good job of it in the curriculum, kind of walking people through symptom management and, presumed anti-cancer effects, which again show up in the animal studies and certainly in several case reports. But hopefully that answers your question. And now I'm kind of wishing we brought CB1 receptor staining to market, because a lot of people would be using, hey, hindsight's 2020. We got so frustrated by CB2 not working. We just canned the project. And I'm trying to remember what we worked on next. It might have been healer.com and our free education content, which was a good contribution. But yeah, if you're investing or interested or wanting to help, please contact us. We love the idea of bringing this to the market or helping someone else do so.
It would just make it so much easier, I think, with oncologists as well, to understand how cannabis can help in that market.
I think it'd be great.
Thank you.
Thank you. Thanks so much for your comments. All right, I'm going to go back to the spreadsheet here for previously submitted. So this was Mary asked, oh wait, sorry. Cynthia was first, and she said, I have 3 to 4 separate migraines with different types of aura. I'm very interested in cannabis and medication overuse headache. So I am, what I'm going to do, because I had it pulled up earlier, is I'm just gonna post a link to an article that I was interviewed in the chat here. And then Shelly, I will remember to get that other paper too. Let me see if I can just do that real quick while it's on my mind. But so the basic is, I have seen people demonstrate something like medication overuse headache when using cannabis, and I think there's some strategies to avoid that. So For those of you that haven't heard of this before, medication overuse headache, or MOH, is basically somebody's got a headache that occurs every once in a while. They learn that taking either Tylenol or an NSAID or maybe an opioid, or there's a number of drugs that can cause this, but they figure out that this helps their headache. So they take this drug and then they start getting their headache more often, and then they're taking more of the drug, and before they know it, they have a headache every day all the time, and they're hooked on these drugs. And both Tylenol and the non-steroidal drugs, which are over the counter and marketed for headache, certainly cause medication overuse headache. This is widely known but seldom talked about. So the question is, does cannabis do the same thing? Can people get a rebound headache when they stop cannabis? And so I think, like everything, probably the single most important factor to avoiding medication overuse headache when treating headache with cannabis is to avoid building tolerance to the cannabis, to always use the lowest effective dose, because then there's much lower likelihood of rebound afterwards. Also, if somebody has a fairly chronic headache, don't just rely on inhaled cannabis to chase the symptoms around. Use orally dosed cannabis to prevent the symptoms at the lowest effective dose. That seems important. Hydration. I think that a lot of people don't drink enough water, and that alone is a treatment for headache. Just becoming more hydrated, and that can take some time to help. Maybe a few weeks of increased hydration can make a big difference. But also, cannabis tends to have this drying effect on the mucous membranes, including in the sinuses and in the head. And so if you're already too dry and the cannabis kind of dries you out a little bit more, that could make things worse. So those are my biggest recommendations from people with headache. And I treat a lot of headache here based on my cranial osteopathic practice. This is one of my biggest specialties. And I have taken people that have failed to respond or been refractory to so many different headache treatments. And with a combination of getting them sleeping better, getting them hydrated, treating them osteopathically, and getting them on an appropriate dose of cannabis, I see improvement in just so many of my headache patients who are thrilled to be using cannabis. And of course, it's safer than a lot of the drugs it replaces. So that's my headache spiel. Let's keep going. Simone, who's next for live?
We have Anna Harvey, Dr. Anna Harvey.
Okay, Anna.
Hello, Dustin.
Hi.
I'm a bit nervous coming on. It's the first time.
Well, I just want to thank you for being willing to show the video, because it does make it more fun for me and probably everyone. So you are welcome here, and be however and whoever you are.
Okay, well, I'm coming from Auckland, New Zealand, and our laws have just recently changed. So we have a medicinal cannabis scheme, and I'm involved in a new cannabis clinic. And I've been doing it part-time, and now it's kind of coming up to more like full-time.
What's your role? Are you a clinician?
I'm a clinician. I'm a family doctor for 25 years.
Awesome.
And as I say, I've just been in the cannabis kind of area for about a year, slowly. And I've done your course, which I found awesome. So thank you so much. And I'm really enjoying these seminars. So it's really great. So, but what I've found, so in New Zealand, CBD requires a prescription. I understand in most places around the world, you can just buy it. And so now I'm getting all of these parents coming to me wanting to put their children on CBD for various conditions that they've heard about in America on Facebook pages and things like that, and hearing lots of things. So, and they're coming to me and I'm a family doctor. I'm not a specialist in neurodevelopmental conditions. And so it's quite challenging, but I also am excited to offer this more, this option for people, because it seems to me like it's a lot safer than a lot of the other options that they are being offered. And anyway, I wanted to ask you about this particular case of this young girl, 7 years old, who has had a kidney transplant, is on immunosuppressive therapy, and has also got the diagnosis of attention deficit hyperactivity syndrome. So the parents have done their research and they want to try CBD. Now, unfortunately, and I kind of think, yeah, okay, it sounds like a good idea, but the specialists are not in agreement, and they are saying that the CBD may affect the immunosuppressive drug. And then also the question from the parents, could CBD affect immunity in a way that may mean that it potentiates this kidney rejection, because apparently this child already has some antibodies towards this kidney.
Got it.
And so
Great question. Yeah, excellent case. So let's back up before we address the case. I think a big part of your new world is the risk-benefit discussion and informed consent, which changes so drastically depending on whether these patients have already tried a slew of conventional treatments, and does the risk of a CBD trial, not CBD treatment forever, but just the risk of a CBD trial, put a container around it 3 months or 2 months or something like that. Does that risk outweigh the risk of doing nothing or doing the next more aggressive treatment? And I think in a lot of those situations, you're going to find that, well, CBD trial is probably warranted here, especially because it's the family's personal preference, and we know it's got such low toxicity. And I have seen it in many young people, help with focus and attention and anxiety. And, in this last year during the pandemic, we've gotten an enormous amount of adolescent patients whose parents are bringing them here because they're depressed and anxious, and maybe, having other behaviors that aren't healthy for them. And we're using CBD and THC because I feel like if we can do a trial and demonstrate that we're getting good results, then we've mitigated other potential harms, right? So getting back to your case with the kidney transplant, so first of all, there is a potential interaction between CBD and tacrolimus and some of the other drugs in that category. Now tacrolimus can be, the level can be checked in the blood, so that shouldn't be too hard to overcome that obstacle. And most likely the pharmacokinetic interaction would occur at a high dose of CBD. So I'll tell you that in most situations, you're going to be able to use a dose of CBD that affects focus and behavior that doesn't do anything to the CYP system, or nothing that's clinically significant. And that you can follow up on. Now, there's also evidence that CBD can decrease graft versus host disease, which I know isn't exactly what we're talking about now, because we're talking about kind of the other direction. Host versus graft is what they're worried about. But there's no evidence to suggest that CBD would increase that or undermine the effect of this drug. If anything, it would raise the levels of the tacrolimus and make it even more powerful, but potentially more toxic. So I don't think that being on that drug or having had a kidney transplant is a contraindication. And I don't think there's anything in the literature that would suggest that.
Thank you.
And so, and then dosing range.
And one other question about.
Yeah, but let me just tell you where I would start. So 7-year-old with attention deficit that's been refractory to other treatments, I would consider somewhere around like 0.1 milligrams per kilogram of CBD as a starting dose. And I would be concerned about drug interactions if you got, say, above 2 milligrams per kilogram. But I think that probably nothing would happen at 2 in most situations. You wouldn't even need a lot more than that.
Oh, great. You've actually almost answered my next question, which was, when do we need to be worried about the interactions with other medications and, the liver and all of that? What are the dose?
Yeah, I mean, it's hard. We don't really know. Not a lot of human studies have looked into this, but based on my clinical experience and what we talk about in the Society of Cannabis Clinicians and other discussions I've had, I think that if certainly if you're below 1 milligram per kilogram, it's extraordinarily unlikely.
Great, thank you so much.
You're welcome. Great questions. Thank you. And thanks for doing the work you're doing. That sounds really exciting. And for joining us. What is it, early in the morning over there, or? Oh, sorry, we muted you. Okay, let's go to the next previously submitted question. We'll do a few more. So this is from Mary. Dr. Sulak, I'm very interested in information and recommendations for those who've experienced these 3 types of neuropathy. So neuropathy that happened after taking statins, neuropathy after chemotherapy for colon cancer, which is very much like the study we saw tonight. That drug is used a lot in colon cancer, and neuropathy beginning after week 6 of shingles. So that's the post-herpetic neuralgia. So wow, I mean, big range here. What are my recommendations? So as always, we talk about treating the patient and not the diagnosis. And so this means if you have someone that's trying to heal their nervous system and heal from neuropathy, first of all, we want to use cannabis in a way that gets them great sleep. We want to use cannabis in a way that promotes physical activity. We want to use the effective dose of cannabis to decrease both the intensity of the symptoms, but probably even more so the bothersomeness of the symptoms. And that is, in general, what that tends to look like is some combination of CBD and THC taken by mouth, usually with breakfast, sometimes with breakfast and lunch. We start at a low dose, we gradually increase it until we get some results. If it's too psychoactive, we can switch and lean more on the CBD. If it's not strong enough and it's getting expensive, we can lean more on the THC. And then if there's breakthrough symptoms, we might use inhaled cannabis. And I've had a lot of patients that love topical cannabis for peripheral neuropathy. I also use some other non-cannabis treatments for peripheral neuropathy, including topical ketamine, which I found helpful. So, it's a really broad answer, but whatever the etiology of the neuropathy, the cause of it, whether it's from statins, chemotherapy, or if it's after shingles, in my mind, doesn't make a big difference. Now, I haven't treated that many cases of post-herpetic neuralgia, but I have had some really successful cases using cannabis where it seems to help a little at first, and then the more they use it, the longer and the better it works. And that's applying it topically and taking it orally. So I think that it's certainly worth a try, and I hope that answers your question, Mary. The other thing is that if the statins induce the neuropathy, then it's likely that one of the mechanisms of action was through depleting coenzyme Q10. And so one might consider adding CoQ10 at a high dose, like 400 to 800 milligrams a day, as part of the therapy to restore that in the body and stop the statins, of course. And then, I guess since we're talking drug interactions tonight, many of the statin drugs do have overlapping metabolism with the cannabinoids. And so if someone's on a max dose statin and they're taking cannabis, that could kind of push them over the max dose in their blood level, potentially. And anyways, I think that's a good argument for considering decreasing statins or using an alternative treatment, or just reevaluating, do I really need statins and how effective are they for primary prevention? Totally different story if somebody's already had their first heart attack or stroke and they're trying to prevent a second one. But if you're trying to prevent your first one, in many situations, statin therapy isn't the best idea, in my opinion, and based on the opinion of a lot of other researchers in that field. All right, better get onto something else before you get me talking about conventional medicine more. Who's next on the live chat, Simone?
Marshall's next.
Hi, Dustin.
Marshall, where are you?
I am here.
Okay, there you are. Hey, welcome to the webinar. So good to see you.
You too. Have you done any work with facial nerve regeneration for Bell's palsy patients?
I've tried, but I'll be honest with you, I haven't seen much of a response in Bell's palsy. Certainly with the hypertonic musculature, that I've seen that relax, but I haven't seen regeneration or restoring function, unfortunately.
You think the high dosages of the steroids that are given before you get to the cannabis has any effect on the nerves, possibly cannot be regenerated?
I mean, we know that steroids can suppress, growth in many tissues. And so I think, right, it's a double-edged sword. We might be trying to address the inflammatory effects while inhibiting the healing effects. And, I think that's tough. Living here in New England, we have a lot of Lyme disease. Bell's palsy is common, presentation of Lyme. And I have not seen, I can't even think of one case where it was obviously responding to cannabis, unfortunately.
I had the partial paralysis.
Yeah. Yeah, we have more to learn about that. Maybe there's something else that we could be doing, like maybe instead of just trying to treat it systemically, maybe a highly concentrated topical, right, where the, the cranial nerves, where the facial nerves emerge. but I'm thinking, I was just pointing
Yeah.
to trigeminal. That's not what we want. We want facial. And I'm not sure where would we put that over here. Yeah, it's tough. It's tough, but thanks. It's a great question. I wish I had a better answer for you.
All right. Thanks, Dustin. Nice
You're
talk.
welcome.
Okay.
Okay. It's getting late. We'll do a few more because there's still some good ones here. Oh, very similar question is up next to what Marshall asked. So can someone taking high doses of prednisone, 40 milligrams a day, and experiencing water retention, extreme irritability, paranoia, and other nasty side effects use CBD, CBDA, or cannabis to taper off the prednisone? Great question. That's from Taru. So, what can I say? The prednisone is being given for some reason, and that's probably some reason that has to do with inflammation that's uncontrolled and needs to be suppressed. Those type of long-term doses nowadays, we see that sometimes with polymyalgia rheumatica, which is a rheumatoid condition that affects mostly the shoulders and hips. There might be a few other reasons for someone to be on that high dose long-term. What do I think about using cannabis? First of all, you could start cannabis without having to reduce the prednisone. So it could be an add-on treatment to try to balance the immune system and get the inflammation under control and potentially support a prednisone taper. I have a patient recently that got off prednisone for polymyalgia rheumatica after using cannabis for about 2 months. So that's something that would be common. Could the cannabis be directly substituted for the prednisone? Where it's interesting, the anti-inflammatory effects of THC have been compared in preclinical data to hydrocortisone and prednisone. And I'm trying to remember what it was. I think THC was milligram for milligram. Don't quote me on this. It might have been half as potent as prednisone, twice as potent as hydrocortisone. I can dig that up. But if you're just looking purely at models of inflammation, there is this capacity to compare the cannabinoids to the prednisone, but one would probably have to take a lot of them. So what do I suggest? Same thing as always, treat the patient, not the diagnosis, get them fine-tuned on cannabis, maybe consider being a little more on the liberal side with their dosing. And then once they're feeling really good and the symptoms are better, that's when I would start tapering the prednisone slowly, of course. And then for anyone that's been on that much for that long, you got to consider adrenal suppression and repleting the adrenal hormones. So a lot of people don't realize that hydrocortisone would be the bioidentical version of cortisol. And prednisone does not do everything that hydrocortisone does. And so someone that may have adrenal suppression, that needs to be worked up and potentially treated with hydrocortisone at a biologic dose, which is usually 20 milligrams daily. I'm loquacious tonight. You guys got me talking. Let's do another live one. Simone, please.
All right, Dustin is up.
Hello, Dustin.
Hello, Dustin.
Nice to meet you, sir. I actually am out in Saskatchewan, Canada. I'm a clinic manager with a network of clinics across the country here. We're seeing great things, great feedback from patients. I wanted to echo something that you said, treat the patient, not the diagnosis. We have a similar slogan that we often say, start low and go slow. And most patients find their rhythm or their sweet spot.
I want to add something to that. The whole line that I learned from my geriatrics professor or faculty member in my residency program, which I think applies beautifully to cannabis, is start low, go slow, and don't be afraid to go all the way.
That's a good one.
Because for some people, you need that high dose. And if you go slow and stop, then you're in trouble. Because I think, it was actually, I've criticized her for this, but Caroline McCallum in her paper with Ethan Russo about cannabis dosing, they said start low, go slow, and stay low, which is kind of the opposite of the idea here. Some people really do need more. But Go ahead. Sorry to interrupt.
No worries at all. I wanted to shift gears over to clinical studies a little bit. There's been some studies coming out of Canada, this one medical cannabis company called Tilray. I would like to know your perspective on studies and how they're viewed internationally. And the reason is because in Saskatchewan and in Canada, especially here in the central region, where the practice of medicine is rather conservative, and doctors have a hard time wrapping their head around this. we often say, well, look to the European Journal of Medicine and all the clinical studies that have come out of there. How can that, what's a good sort of tactic to get doctors to really appreciate this on a more international level?
Wow, great question. Sounds like a big challenge to me. First of all, I'm familiar with the data that Tilray's been publishing, and I think they do a good job. I know Philippe Lucas, who kind of directs their research program, and I think they're asking good questions. And of course, they've got this industry aspect to it, but that doesn't ruin it for me by any means. I think they've put out a lot of good stuff, a lot of observational data, and then people kind of poo-poo the observational data because we want gold standard randomized clinical controlled data. And I think that old paradigm is, just overused and it doesn't represent what the patients you're taking care of and that I'm taking care of are really going through. So, I like what Tilray and some of these other companies, Canopy or Spectrum, they put out some a good paper that I was a co-author on about opioid dose reduction using cannabis, and another one coming out soon about pain dosing. So we're making inroads. It probably seems like it's a snail's pace from your perspective. I've been doing this 11 years and it still kind of feels like a snail's pace, but it's actually picking up momentum. And I think that the kind of dissatisfaction of physicians within the conventional system and of their patients is really driving more people to be open-minded about cannabis. And then what I encourage a lot of my patients to do is to tell their other doctors about how well this is working. I send copies of my chart notes to their doctors. I don't know if at your clinic you have the capacity to put together a little summary and send that to the various doctors that are involved in people's care. That has worked so well for generating referrals and for just kind of establishing this as a legitimate treatment. So that would be, a procedure worth considering, just opening lines of communication with their primary and their specialists and showing how well it's working. Because after that third or fourth patient says, that other drug you gave me didn't work, but then I used cannabis and it did, it's going to catch the doctor's attention. So, I hope that answers your question. I think the scientific literature, it moves slowly and people don't read it as much, especially clinicians in the trenches rarely read journal articles, and it takes kind of a special breed to be early adopters of cannabis. But wow, we have a lot of them on the webinar tonight, so we're not alone.
Absolutely. Well, we'll keep our fingers crossed then for more of these studies to come sooner than later.
Yeah, thanks for doing the work you're doing, Dustin, and for joining us tonight.
My pleasure.
Okay. Let's do another one from, I have the link. Let's just give this. So the link about the anesthesia paper that came out, oops. I did a direct message to someone who was chatting to me, but I'm going to do a non-direct message. There we go. So in the chat, there's that link if you want to bring that article to your anesthesiologist. Okay, so now we are going to what type is recommended for anxiety and digestion, thyroid nodule and autoimmune, and candida. I've tried regular CBD without a lot of results. I have a new state card, but would like to try options from Healer. Okay, so let's pull this apart. It's a really tough question. What's the answer to this question? It's come into the clinic for an hour consult, and I'll ask you a bunch of questions about yourself and do an exam, and then maybe have an individualized treatment plan that we generate for you. But without that, I think we can still learn from this question. So let's start with anxiety. CBD seems to work for a lot of patients with anxiety. I'd say adults typically start responding as low as 10 milligrams. Seldomly is it lower than that. Some people would need a much higher dose, like 20 to 100 milligrams if the anxiety is really severe. Some people only get partial response to CBD. No matter how much they take, it doesn't fully resolve the symptom. It just helps a little bit. And we believe, based on my experience, that taking some CBDA with CBD potentiates it, makes it more potent and more effective at a lower dose, allowing for a lower cost overall. And so I think for people, CBD can be useful for anxiety. There's some human data that suggests that if you take a really huge dose of CBD for anxiety, it doesn't work as well as a moderate dose for anxiety. But I think if you start low and then methodically titrate up to whatever you can afford, or say to 100 milligrams or something like that, you're probably going to see how well you respond, and that would be a trial. Now, what about THC and anxiety? Yes, acts via mostly a different mechanism than CBD. Very effective for anxiety, often in lower doses. Certainly, people that are anxious who inhale cannabis are more likely to have this paradoxical effect where the anxiety gets worse. And some people can inhale cannabis and the anxiety gets better. Some people it gets worse. Some people, it depends what type of cannabis they inhaled. Even if there's two different THC dominant varieties, one could be bad for anxiety, one could be good. I think that the best thing to do with THC for anxiety is to take it at a low oral dose to prevent the anxiety. But that would be, if the anxiety is more of a chronic issue. If it's rare episodic anxiety, like public speaking anxiety or something like that, then taking it preventatively might not help. But figuring out if like a certain dose helped and then being able to rely on that dose could be very useful. So then a question about digestion. It's a pretty broad question, but wow, appropriately dosed THC can regulate the digestive tract beautifully. I've heard people telling me it helps with diarrhea, it helps with constipation, it helps with pain, helps with nausea. Obviously, that's one of the things we know most about how THC can help the gut, and it can help with motility, typically slowing motility down when people have really fast transit. But I have in some cases seen people who are slow and start taking THC. I'm always a little worried, is this going to slow them down even more? And they come back reporting that they're better, and who knows why. So it can speed up motility in certain patients as well. It can relax the lower esophageal sphincter, and THC we're talking about now could theoretically make GERD worse. I don't see that a lot, but I think it probably happens in some people with THC, and GERD being acid reflux. And then, what's often not talked about in digestive treatment is THCA, which is an excellent anti-nausea treatment without the psychoactive side effects. This has been proven in rodents, and also I've seen it in my patients, very low doses, like taking a little bud, chewing it a couple times and putting it between your cheek and your gum, or sipping on cannabis tea to get the THCA can be useful. CBD. So what about CBD and nausea? I've seen it help. I've seen it make it worse. CBDA seems to be more potent anti-nausea drug, especially in animal studies. It seems to help in my patients as well. When people take too much CBD, usually the first thing they complain about is loss of appetite or some kind of a vague nausea or something like that. So, with CBD, it could be a double-edged sword, could make things worse instead of better. But that's the quick summary. Thyroid nodule, I'm going to skip. Autoimmune, treat the patient, not the diagnosis, because so many people with autoimmune disease can benefit from cannabis. And then I think we talked about candida a lot right now. So wow, big question there. But for Amy, who asked it, and for the rest of you, I'm only licensed to practice medicine in Maine, but we have a lot of patients in other states and other countries that want to talk to me. And what I am offering, and I have been offering for a long time, is we can get on the phone or a video chat. I can take your case and I can provide education that will inform you around how you could use cannabis. I can't establish a doctor-patient relationship with you, but I can take all that education, all the information I provide, and send that to your local doctor to empower them to continue working with you along these lines. And so for people that have complex questions, I'm very happy to talk to them and see what I can do to help. Okay, I think let's just, oh man, I didn't get through the spreadsheet. I'll go a couple more here because I think that they can be fast and they're good ones. Do you recommend decarboxylating CBD before making it into a tincture? The answer is yes, but only partially decarboxylate it. Leave a little aside so that you have some CBDA. CBDA is better absorbed. It's highly potent. It seems to make CBD more potent. I love CBDA, and I think even if you have a little bit, it goes a long way. So keep a little bit of it raw. Next question. There seems to be a good amount of research and anecdotal conversation regarding cardiovascular conditions in cannabis. However, I don't hear much about its effects, positive or negative. And then the case is that I have AFib and I'm experimenting. Few observations. Inhaling seems to trigger a rapid heart rate and possibly an AFib event. So atrial fibrillation is a condition where the heart is, especially the top part of the heart, is basically beating in this extremely irregular fashion. And it can be dangerous because it can lead to blood clots. Basically, the blood can pool and start to clot and then get thrown to different parts of the body. And it can also predispose people to more dangerous arrhythmias. Now, some people just go into AFib every once in a while and they're able to get themselves out either by taking a drug or gagging themselves, or they just come out spontaneously, or things like that. So it sounds like this is a person that's kind of in and out of AFib, and they think that inhaling cannabis may have put them into AFib. I would say that that is entirely possible. Inhaled cannabis, especially at very high doses, especially in people that have very sensitive cardiovascular systems, can trigger arrhythmia, not just AFib, but other forms of arrhythmia. And so I'm always careful with inhaled cannabis in people that have arrhythmias. It doesn't mean it can't be used, means you just got to be careful. This person should be on an anticoagulant. I don't want to say should be, I don't know the rest of the details about the case, but most people with AFib that go in and out would be on an anticoagulant, and that would offer some level of protection if they're experimenting with cannabis. The person also, Jackie also said, too much THC in a tincture or edible, same thing. Exactly, too much, but the right dose in a tincture or edible, probably not the same thing. So basically what happens is a few things. THC can decrease blood pressure a little bit, especially in an excessive dose, especially inhaled, and that's a brief decrease in blood pressure. But to get the blood to where it needs to go, there tends to be an increase in heart rate. So you've got this increased sympathetic, meaning fight or flight nervous system, signaling to the heart that would increase the heart rate and therefore put more demand on the heart and be more likely to trigger arrhythmia. That same signaling is what we block with drugs called beta blockers that are used to control heart rate and prevent arrhythmia. So we don't want to increase that too much. I mean, a little bit should be okay, but that's kind of where getting the right dose comes in, and the right delivery method. What else can I say? Jackie says CBD seems fine, but don't know for certain if it's effective in controlling symptoms. But it could be, but I feel it needs to have some THC alongside of it as well. And then she says an important comment. I do like to have CBD in my system in case of a stroke, which I understand may be beneficial in mitigating stroke damage. So let me expand that even more. THC and CBD in animal models, and there's some human data, observational human data, that supports that this notion translate. Both have been shown to protect the brain in case of stroke and to protect the heart in case of heart attack. And that's been especially true with THC. Even in very low doses in rodent studies, ultra low doses, you can prevent the damage of a heart attack with THC in rodents, and some data that supports that translating to people. Also some data showing that high doses of CBD can precipitate a cardiac event, which is exactly what what Jackie's talking about. So be careful with high doses. And then yeah, I mean, I think people with AFib, I've treated so many with cannabis over the years. It's really about getting the dose right and being very careful with inhaled THC. So for you, Jackie, I would say, yes, use a combination of CBD and THC. If that's what works best, just start low, go slow, and don't be afraid to go all the way, but you probably won't need to go all the way. And if you do need to go all the way, we're probably missing something. Meaning if you require a really high dose that's causing cardiac side effects, there's some other part of the equation that's not being addressed here. And just as an aside, my patients with arrhythmia, I treat most of them with magnesium and iodine. These are treatments that were popular for arrhythmia up until the 1950s. They're very safe. They have a lot of side benefits. So that's something else to consider. Oh, and I treat them with osteopathic manipulation. And I'll tell a story. This was years ago. Wow, I haven't even thought about this guy in a long time. But he came in and he was using cannabis for anxiety. He had been for a long time. I'd seen him for about 3 years, I think. And then he came in one time and he said, "Doc, I can't smoke. Every time I do, I get this rapid heartbeat." He had a Holter monitor. It was a SVT, supraventricular tachycardia. And so I treated him osteopathically once. I said, get on my table, let's see what happens. He had this incredible strain in his mediastinum and in the tissue around his heart, the pericardium, and we treated and released that strain, and he was able to smoke again, and he loved me for it. So that's an N of one story, but you know, sometimes it's not just a chemical cause, and it sometimes doesn't need a chemical fix. There can be something structural here that would impact the physiology of those tissues. Okay, it is almost 9 o'clock. Let me just see on this list if there's anything else. And then Simone, please line up the last live question. Okay. Yeah, no, I think that's pretty good. William Haas, Dr. Haas asked any ideas on the treatment of post mastectomy pain, and I would, you know, suggest topical basically as well as an oral treatment. And CBD has been shown to be an antifibrotic. Oh, and this, gosh, I forgot to mention this with our friend from New Zealand, and I forget your name. I'm sorry, and I don't see you on here. But that's another good point about using CBD in someone that might be risking injury. Oh, there you are, Anna. Because CBD can prevent fibrosis, which is something that happens in the kidney sometimes with that you know, kind of graft, you know, not graft versus host, but host versus graft, like that antifibrotic property may be beneficial actually, and there's a little bit of data on that. There's a good Renal Review article that discusses a lot of these points. And the author is my friend Josh, whose last name I'm forgetting right now. I'll see if I can get this for you. I want to also mention that my book, which I thought would be out last year, is finally coming out in June. It's the Handbook of Cannabis for Clinicians. You can pre-order it on any of the big booksellers. You know, just for all of you, this forum here was never intended for clinicians. And that's why I'm so flattered and appreciative for all the clinicians that join. I kind of was planning to separate my two worlds and teach clinicians over here and teach non-clinicians over here. And I love the mix. I think it's brilliant. And I also welcome feedback, because as I listen to myself tonight, I think I might be speaking more in clinical lingo than I usually do. And I want to watch out for that. I want to make sure that I translate to make this accessible to everyone. So I'm noticing that tonight. The book is completely in clinical lingo. So if you like that, dig into it. There's hundreds of references in it, and I think I make it really accessible. So having said all of that, let's finish with another clinician. Thank you, Lonnie. Go ahead.
Hi, Dustin. It's a pleasure to see you, and thank you for taking my question. I loved your presentation tonight, and I have a client that I've been working with a bipolar disorder and not responding well to various medications, and wanted my help in terms of dealing with her mood. I'm the kind of person that's using cannabis as a tool, as we talk about, you know, go low, slow, but go all the way. But the key is I don't want her relying on this. I want her to rely on tools that she's going to learn. But sleep has been the first thing that I'm targeting. And I was wondering if you had any thoughts about how to approach her mood imbalances.
Yeah, great question. So, well, I think that, and I'm sure you know this, that after addressing sleep, daytime use of CBD could be helpful, but my guess is that it's going to be expensive at a dose that could really have that, you know, strong mood balancing effect. CBD might be too much. Has she already tried it?
As a matter of fact, yes, and that is the problem right there, the cost. It's prohibitive, which I wanted to wrap up by just kind of telling you how I have a workaround for that. But yes, CBD does help during the day, but we're reaching limits because she needs higher and higher doses. She's relying on it too much. And I was wondering, you know, do you think that using perhaps an indica strain, something that's a little bit more dominant in the sedative properties, to calm her down rather than impairing her, you know, her psyche, do you think it's going to focus more on calming that part of the nervous system?
Right. So, you know, before CBD was ever available, we took care of a lot of patients with bipolar with THC, you know, as their dominant treatment. And the vast majority were using it just in the inhaled form. And so, you know, knowing what you know about cannabis and bipolar, that's probably the worst idea. And it still works great for a lot of people. And what I observed was that the biggest factor there has to do with, are they getting restorative sleep? Are they using cannabis to sleep, or are they using it to stay up all night and party? And that different use pattern can make all the difference, because people with bipolar, so there's research out there, there's evidence. I think a study published in 2011 or 12 showed that people with bipolar who use cannabis are more likely to have better neurocognitive function than those who don't use cannabis, but they're also more likely to have more manic episodes. So how do you put those two together? I think what it really depends on is how one is using it. So yes, Lonnie, I think that because you haven't gotten the results you're looking for with CBD, I would start leaning into THC during the day. I think indica is good, and I would also keep inhalation on the table, because they're, you know, at a low dose of inhalation, you might get some really profound results. And as we've talked about before, that transition from suffering or stress to feeling peaceful and whole, that can happen in a minute's time or a 5-minute period, that rapid transition is really educational for a lot of people, especially if they're working with Dr. Lonnie regularly and actually getting those kind of tools to understand what they're going through, you know, and talk about it with someone who has a language to give them a framework to understand what's happening to them. So I think there can be a lot of value. I would say, now that you've got this client sleeping well, I think that you have to be a lot less concerned, you know, cautious about THC use during the day.
Well, one of the things that I've added to my practice also is cannabis-assisted psychotherapy. So I'm in a state where it's medically legal, and this is something that's actually really fascinating, because being a psychedelic, it really is sort of a baby step towards the other substances that are out there. For people that lack the skills, it's something that trains them for it. But in a lot of cases so far, it's enough to get a lot of breakthroughs just during the therapeutic session. Something else I wanted to share with you.
Wait, don't stop there. I want to ask you. So the cannabis assisted psychotherapy, is this more talk oriented therapy or more somatic therapy, or both?
It's talk therapy. It involves more just getting them into a great state of relaxation. I learned about this during a seminar that I just loved their approach, using a very interesting blend of sativa, hybrid, indica, and then they teach people how to make their own indica strain that is laden with CBN. Basically, just leave it open and exposed to sun for a few days. But now the hypothesis there is that the CBN gets you into the liminal state. So you add this hybrid, you make a salad out of it, as we've talked about, and now you've got something that's triggering a liminal state while you're getting into relaxation, meditation, music, and a guide that's talking to you and asking questions. So it's a fascinating new modality that I'm working with, and I absolutely love it. There are clients who we've had difficulty talking about certain issues in the office, and I find that this suppresses that ego just enough. It's not as dramatic as psilocybin or MDMA or something like that, but it's just enough. And that's
it opens some doors.
The onset's quite quick, and it doesn't last that long, so we don't have to be there for 6 or 8 hours. So big difference. It's a game changer.
Awesome. Lonnie, I love hearing about that. Thank you. That's beautiful work you're doing. Lonnie is in Florida, for those of you that are interested in learning more about the work he's doing. Thanks for sharing.
If I might, a quick question
about
sure. CBD. I've been making my own CBD tinctures and oils and things like that. I've had patients that are having difficulty affording CBD. So I found a great source of boutique flower. So they actually offer 7 different strains, indica, sativa, everything in between. And I actually recently purchased the keef. So it's a CBD keef. And I'm wondering, what are your thoughts on how to use that? And the question is, can I add that to the tincture to add the CBDA component?
Yeah, CBD keef is probably great stuff. That's, I mean, terpenes and CBDA right there. That's powerful medicine. I think that's a great idea. You know, getting it to dissolve, you know, you can see how well it dissolves. I haven't tried it before. You may need a little gentle heat in order to get it to dissolve, but I think that's a great idea. You know, keef has some plant material in it. You're going to see a little bit of stuff at the bottom of the bottle, but you know, people can shake it up. Yeah, yeah. Well, depending on the good stuff may have been fully dissolved or maybe sitting at the bottom of the bottle, but either way, give it a few shakes just in case. But great point, Lonnie. Thank
I
you
will
for the
keep
work
you
that you're
posted.
doing.
Thank you for your input and thank you for your tutoring. You've just been amazing and you've inspired me to go on this path and share this knowledge with other people. So thank you for everything that you do for us.
You're welcome. Thank you all. What a wonderful 2+ hours. I love having you. I look forward to seeing you next month. I'm not going to announce our special guest next month because she hasn't confirmed yet, but there should be a good one. Some of you may be wondering, why didn't I cover the new PTSD study that just came out this month? And that's because I'm saving it for next month. We're going to talk a lot about opioid use disorder, not just using opioids for chronic pain, but actually substance misuse, and then also PTSD. And so we're going to do that all next month, unless something changes, but hopefully that'll be the case. And I know that some of you came on later after I made these announcements. So I just want to tell you again real quick that Healer just launched a topical product. It's a hydrogel and it's got CBD and CBDA along with menthol, copaiba, and limonene. It's really effective. We designed it for pain, but it can help with other conditions. And so that's available at healercbd.com. 20% off Healer products with the code webinar. And if you feel like you've received something of value tonight, I encourage you to give something of value back to the world. Give it to anyone, your neighbor, your friend, I don't care. Make an exchange. Exchange feels good. If you want to make an exchange with me or with Healer, just sign up for our course. Again, there's a discount code for that, which is $50 off. That code is webinar as well. The course, I forgot to mention this. The course is soon going to be available in Spanish. We got it translated, and we're going to be releasing the online course in Spanish. And yeah, if you want to exchange, go to healer.com or healercbd.com, buy one of our hemp products, use it yourself or give it to a friend or sign up for the course. And that's enough promotion. Love to you all. Thank you for giving me the opportunity to do the work that I love to do. It's so wonderful to be with you in this digital format, and I will see you next month.